Hello, good evening. My name is Dr. Chikophe. I'm an anesthesiologist, an active member of the Kenya Society of Anaesthesiologists. The Kenya Society of Anaesthesiologists is a member of the World Federation for the Societies of Anaesthesiologists. And I'm here and proud to be celebrating the World Anaesthesia Day. It's an important landmark in the trade of anesthesia. And maybe before I even tell you what the World Anesthesia Day is all about, I want to remind you what anesthesia is and what it is that anesthesiologists do. So anesthesia could be described as just a reversible loss of sensation and consciousness, and this is drug-induced. So we may be boasting about complex surgeries, advancing in surgeries, but then surgery cannot happen without anesthesia. A lot has been talked, a lot has been said about anesthesia. Of course, it has its history. You could go all the way back to biblical times when God created, the world, the universe. But there's one more thing he wanted to create. The most beautiful thing in the world was a woman. But he knew he had to put the man under anesthesia for him to be able to create the woman. So I think after arts, after creativity, the next trade is anesthesia. And there's been lots of documentation. Even the days of Hippocrates, they defined anesthesia. And a lot of drugs were tried, but I think the first and successful demonstration of anesthesia happened in Massachusetts General Hospital in the year 1846. On this day, there was a demonstration, successful demonstration of use of diethyl ether for anesthesia. And I think thereafter, anesthesia has grown from just being an art to an exact science. Anesthesiologist, for example, is a medical specialty that is concerned with the perioperative care of patients. Of course, it looks at the use of drugs, how the drugs interact with the body, what the body does to the drugs, how we can start the anesthesia, how we can stop it, and how, of course, we can tailor the medicine based on the profile of the patients. So it, of course, includes the use of anesthetics. It also includes intensive care medicine, whereby we take care of these critically ill patients who undergo maybe complex major surgeries. But sometimes you have to meet these patients just before they go into anesthesia. And so we have to do a bit of emergency medicine. And long after they recover, they may actually need follow-up in the pain clinic. So anesthesia looks at the use of drugs, the anesthetics, their interactions with the body systems, the perioperative care, which includes intensive care medicine, the emergency medicine, and pain medicine. All right, so a lot of stuff has happened, because if you look at the Second World War, most of these patients or most of these casualties of war who were taken to surgery, many of them would actually die in the immediate postoperative period. And so one perioperative nurse, an anesthesiologist, and a surgeon decided to do to put up an area where they will observe patients. And of course, the nurse's work was to monitor the progress of these patients in terms of vital signs. And if she noted worrying trends, she would call an anesthesiologist if she thought the cause of this deterioration was directly related to the anesthesia or was metabolic in origin. If she thought the problem was surgical in origin, she would actually call the surgeon on top. And so with this observation, they realized that they could reverse the mortality by nearly 50% of the time. And the post-anesthesia care unit, which was first started in 1946, became the modern day ICU. Thereafter, I think in 1953, there was a polio epidemic, and the guys in Copenhagen actually came up with the first mechanical ventilator. And the mechanical ventilator has grown to be not only a life support tool, it's also a diagnostic tool because it tracks the progress of patients. Around 1957, we had the first blood gas analysis, again in Copenhagen. And then in 1972, there was the introduction of the pulse oximeter, which is an invasive way of measuring oxygen levels in the body. So for us to be able to practice this trade of anesthesia, we've had to learn the science, we have had to learn the technology, but we've had to remember where we started, where we're going, the day-to-day milestones, which are very important in shaping the future of our practice. So the role of the anesthesiologist is continuing to grow, because I remember the day I told my family that I was going to do anesthesia, they became pretty mad with me. Why am I doing a job that involves just making people sleep and wake up? Why do you have to wait for a surgeon to plan for you? Why can't you plan for yourself? But then I decided that was the passion that I had. And if I was to go back to school, I would still do the same thing. So when it came to December 2019, there was an interesting observation in Wuhan whereby patients were dying. And when it was investigated, it was thought that these patients were dying because of bad pneumonia, ARDS, that was related to the coronavirus. And, you know, of course, patients were dying. And in January this year, it became a global health emergency. Of course, in Kenya, around March 13th, we had the first case documented in our setting. So we thought maybe initially, when we started discussing here in Kenya, coronavirus was thought to be purely an isolation problem. So if you built a ward and you have a tank of oxygen and a device that can deliver, you know, oxygen in one way or another, then you're good to go. But much later, when this patient started deteriorating, we realized that we had to involve the anesthesiologist in administering the oxygen in both invasive and non-invasive ways, in tweaking the oxygen to just ensure that the outcomes were good. Therefore, it meant we had to involve anesthesiologists as team leaders, of course, in the triage of patients who were critically ill, in the initiation of life support in the form of, you know, putting them on the mechanical ventilator. We had to do what you call endotracheal intubation, which involves sedating these patients. Of course, we're using our knowledge in anesthetics, paralyzing them, using a laryngoscope, visualize the windpipe, put some tubes, connect these patients to the mechanical ventilator, monitor them, monitor their hemodynamics, as in the blood pressure, the heart rate, and monitor if this mechanical ventilation was hurting the patients in other ways. But the whole process was not without problems. Number one, it was scary because we had been warned that this disease is actually highly infectious. And the recommendations that had come out were that the most experienced person when it comes to airway management is the anesthesiologist. So by default, we became the team leaders of the airway management teams. So we had to ensure that all the protocols are followed. Because we're the ones who had done a lot of endotracheal intubation, we were to monitor and watch that the other members of these teams were following the instructions so that at least no one gets exposed to these viruses. Of course, at the end of the day, we were the main drivers. We had to do the laryngoscopy, put the tube where it was supposed to be, and make sure that the patient doesn't cough, and make sure that there's no generation of those highly infectious particles. So you can see that the work of an anesthesiologist is not without stress. You are a leader, but you're leading a team that is also very, very anxious. So there are expectations from the patient and there are expectations from the members of the team. Of course, after we intubate these patients, they'll have to be nursed in the critical care rooms. And majority of the people taking care of these patients are anesthesiologists. Maybe there's a difference here in Nairobi, but when you look at all the counties, anesthesiologists are the ones who are on the forefront. They will triage the patients, decide which patient can go on oxygen therapy without the tubes, which patients can be managed with the tube, how do we monitor, in terms of blood gas, how do you sedate them, how do you make them comfortable? And long after they come out of that life support, we have to rehabilitate them because most of them go into weakness. And for them to be reintegrated into the society, they need a bit of, rehabilitation. So you can see that there's a lot of responsibility that the anesthesia practitioner has to undertake. We are also the first response when it comes to resuscitation. These patients would actually crash, and you're hoping that somebody is ready to go and save them from dying. So we're forming parts of the first response teams. But we have other roles as anesthesiologists because the country was looking at us, okay? We had to provide anesthesia for the patients that may have had exposure to COVID-19. We had to take them to theater for the operations, especially when they have dire emergencies. So initially, we had even postponed anesthesia and surgery for elective cases. We were only doing the emergency cases, trying to restructure the rotas so that we can have enough coverage for emergency, while at the same time allowing time for practitioners who had been working before to go and rest, re-energize for the next block of days where we'll be working under intense pressure. So at least I could say right now, maybe there's an increase in the number of planned surgeries based on the figures that we're seeing, but I know that is changing. So we have been doing provision of anesthesia in these times. We have also been involved in medical education. Like, I'm proud of the Kenya Society of Anesthesiology for having done all these webinars. We have been educating, I think, our colleagues. We have had a webinar every Thursday. We have been talking about protocols from intubation to mechanical ventilation to fluid therapy to sedation and to rehabilitation. The Kenya Society of Anesthesiologists, under the leadership of some members, have actually been involved in the initial protocol for COVID-19 management. So we've been part and parcel of the COVID response here in Kenya. We know that this is a new disease. All the drugs that we've been trying to use sometimes do work, sometimes don't work. So there's variable, success. But we know some of our members are actually involved in research. One of our key members is actually involved in the Africa COVID-19 critical care outcome study as the principal investigator for Kenya. We know that there's a convalescent plasma trial, which is happening in Kenyatta University Teaching and Research Hospital. The principal investigator is actually an anesthesiologist. So we actually have been doing quite a bit. And today's theme is about now the well-being of anesthesiologists. One, we know we have to perform our duties, but at the same time, we know we are human beings and you're vulnerable to both infection and mental health problems. By the very nature of this disease, COVID-19 is an infectious disease, highly infectious disease. So the process of trying to put these patients on life support, you are endangering your team and yourself. But by the very nature also of the anesthesia practice, we are predisposed to mental health problems. When it comes to the infection, we know we have lost colleagues. We have lost some anesthesia providers. We have lost colleagues in other fields who are not necessarily anesthesia providers, but we work together. And some of these colleagues that we've lost are people we've gone to school with. So you can imagine being the first on call and then admitting a colleague who is critically ill, hoping that you're doing the best for your colleague, but then they end up not making it. So that calls for, a support to the anesthesia practitioners. When it comes to mental health, we know very well that this practice is demanding. Number one, you get very sick patients. You're the leader. It could go anywhere. It could die. When they die, of course, you're first to be blamed. When they survive, no one thinks about you. So that is a source of stress. There's too much expectation. If you perform, no one says you've done well. If you don't perform, of course, you can be easily penalized. So you realize that the very nature of the practice is quite stressful. We are also predisposed to, drug addiction by the very nature of the practice. So for example, if we have underlying psychosocial problems, we find quite a number of us going into drug abuse. And also the ergonomics of, the practice and environment. Sometimes you find you're the only one lifting a 150 kilogram person on your own. Your other team members have left you because it is your responsibility to ensure the safety of these patients. So anesthesia is quite stressful. We have lost colleagues, we have lost relatives. And the fact that, there's the social distancing, whereby even if you're stressed, you may want to meet your therapist, but you cannot meet them in person. It has to be probably over Zoom. There's no place to shoot pool. As soon as you're through with work, you just go straight home. You're hoping that the home environment is good. So anesthesia is a taxing profession. Of course, there's this constant risk to the biological agents. I've talked about the highly infectious viruses. Of course, you're talking of COVID-19, but before then, we know of some anesthesia practitioners who've gotten infected from the operating room. We know there are other hazards like radiation hazards. Those of us who've worked in cardiac catheterization labs, especially for pediatric practice, you have to be exposed to radiation, but also the practice of wearing those heavy lead gowns, it really gets you exhausted. And even right now, because of the very nature of the practice, again, we have to wear protective equipment, which is not very comfortable. We sweat, we become thirsty, we become dehydrated. You can't even access water, even if you have it, just because you are dressed or you're donned in those complex protective gear. It is quite a taxing trade. We're also predisposed to electrical, dangers. It could be theater fires. It could be short-circuiting of the equipment that we work with, right? We are also predisposed to organizational, stress. Like, for example, a leader in anesthesia, apart from them doing the clinical practice, they may be doing the rota. They may have to take care of a colleague who is bereaved, or the colleague may be sick. All that they have to do. There are expectations in terms of, finances. Like right now, we know we have problems because let's say the colleagues at the University of Nairobi, for example, they're expected to carry out anesthesia duties. But then again, when you look at the, the money, the revenue stream, there's a problem. You are entitled to some allowances. So you go to work, you expect to be compensated. All these are sources of stress. And you know very well that sometimes we are predisposed to violence. Yes, a colleague of mine actually lost a patient, and the family that came to see their relative actually had to attack my colleague, who was still trying to sort himself out immediately after losing a patient, because they're very, very stressed. So anesthesia is quite a taxing trade. So what are we doing about this stressful work that we do? Of course, number one, we have to be each other's keepers. The other day I called my senior colleague. We used to meet every day in the changing room before COVID-19 started. I hadn't seen him in a long while. I know he's a bit old. I know he has the risk factors, so he's been excused from coming to work. So I called him to just check on him, and he was really happy that, I was calling him to just say happy, because to just say how he's doing, just see how he's doing. Because most of the time when you call a colleague, you're either calling to, consult him or tell him, I'm leaving, but there's more work for you. But that thing of just calling a colleague and telling him, you know what, I was just checking on you. I haven't seen you in a long while. I hope you're doing well. I know you have this and this risk. Are you doing well? That was really, really nice. He said so. We have to talk, because as individuals, we may be predisposed, and we have to agree that it is actually true that you have that predisposition. So we need to develop insight. It's been shown that doctors are the worst health seekers. So we need to realize that we have situations that need to be addressed by other clinicians. Personally, I lost a colleague who I went to school with in undergraduate. I admitted that colleague to intensive care. I did the best that I could. I was not able to sleep for 3 days when I lost her. So I actually had to see a counselor, and she told me these things happen, so she gave me lots of encouragement. And I was really happy that I actually went and talked about it, because she made me feel better. I thought maybe I would leave critical care, just because you really feel bad when you lose a colleague. That was the lowest point in the practice, all right? So anesthesia is quite a stressful situation. Let's talk to each other. Let's organize our rotas so that we get enough rest, so that you're ready to come for the next shift. Let's try and balance between family and work. I know right now, I think our families are enjoying quite a bit of our company, just because I think the COVID rotas, you would work, of course, for a long time and maybe take a break for like a week, which our families never used to see. So now we've enjoyed a lot of company. I think many families are bonded, and I think that should continue, for a long time or forever. So we try to make time for our families, because I think it is therapeutic to just talk to your children, talk to your wife or husband. It's really, really, really good. I know we cannot go out. We cannot go for shopping. We cannot go to have those drinks. But I think our families are really benefiting. Let the rota try as much as possible to favor us. Of course, we have to do what we have to do. Let's communicate. Let's update ourselves on the latest advancements in therapeutics, mechanical ventilation, intubation, to just make sure that you don't get exposed. Let's share that knowledge. So every time you get a new idea or you get a new paper that you've understood better, share it with your colleagues, all right? The new infection control simulations on how far the virus can spread, that is very, very important to share. Of course, we are also part of the public, so we have to do what is important to us, as not only as doctors, but also as members of the public. You know very much that the virus is still with us. I would urge all members of the public, including our colleagues in anesthesia, of course, to listen to experts, not to listen to politicians. Yes, the numbers are creeping up right now. A few weeks ago, we thought we were flattening the curve. But every day we watch the TV, we see that the numbers are coming up. Every day we watch TV, you find that there are 10 or 11 or 13 mortalities, and you're wondering where they're coming from. So this thing is with us. Lastly, I want to quote the words of Maurizio Cecconi, who is the president-elect of the European Society of Intensive Care Medicine. He says, "I am an ICU doctor, and I can tell you that I think I have made a bigger difference wearing a mask and asking others to do so than increasing the ICU capacity by 5 times. Trust me, it is more effective and sustainable to adhere to these public health measures than to increase the ICU bed capacity." So if you're thirsty, you have to find a way of, quenching that thirst. Don't go to the club. It's really crowded. We saw it last Friday when, it was made, it was said that the curfew times have been adjusted. We know here in Nairobi, all the pubs went crazy. And we're seeing quite a bit of those now coming to the intensive care units. So this disease is still with us. Try and be safe. Your family needs you. You need your family. The anesthesia family needs you. The nation needs you. The bigger community needs you, because we must write. We must document. We must practice. We must be happy. And we have to keep on keeping on. Thank you very much. I was hoping that members of the Kenya Society of Anaesthesiologists executive will be on board. I hope that if there are any things that you need to clarify, or if, you could still write on the Facebook page, and then we could answer you back. Thank you, and have a good evening. Stay safe.